Hi, my name is Bruce Potenza, and I'm the director of the UC San Diego Regional Burn Center. And we're here today to do another short video clip training for pre-hospital. Today we're going to talk about burn resuscitation and wound care. And we're going to keep this fairly basic for the pre-hospital area. So we're not going to talk about all the fancy types of wound care things that we have here at the burn center, but I want to talk specifically about what you have in the rig, what you can use, and how we can bandage these patients up successfully for a quick transport or even for a delayed transport should you get caught out on the scene and unable to transport the patient back to us. Likewise, for burn resuscitation, I want to keep it just to initial Parkland formula resuscitation, similar to what you do in trauma. Give certain amounts of aliquots of fluids based on the patient's body surface area that is burned, as well as their weight. And we'll go through all these things one by one. So burns are a little bit different. In trauma, we all know that when patients lose enough blood, they become shocky. They develop class 1 through class 4 types of shock. It's based on their hemorrhage. And the way we fix this is by volume expansion with crystalloid or with blood products, and of course, stopping the bleeding. In burn shock, this is different because we're not losing any red cells. We don't have any vessels that are lacerated. But what we do have is a situation that which the thermal injury to the skin causes the release of a lot of cytokines. These cytokines then cause vasodilation of your venous pool and also causes the capillaries to begin to leak. Let's explore that just a little bit. First, who needs to be fluid resuscitated? Most patients under a 15% total body surface area burn can do well just with oral nutrition, oral replacement. That's the same as class 1 shock. If you have class 1 shock, you go to the blood mobile, you donate a unit of red cells, what do they give you? They give you some juice and they give you some carbohydrates. Here with burns less than 15%, and maybe even up to 20%, we do the same. You're going to just be replenishing the fluids that you're going to lose by oral intake. Now, if your face is burned, that's out of the question. Then we need to do some IV resuscitation. But for burns that are 15 and certainly over 20% total body surface area, this release of cytokines is intense enough to cause a significant amount of fluid shifting and intravascular volume loss. What happens then? When the cytokines are released, and in particular IL-1, IL-2, IL-6, and probably the biggest actor here is tumor necrosis factor, when that begins to work on the vascular endothelium, the cells that line the endothelium, if this is my capillary, and my endothelial cells, I have two, one on each side of the capillary. If the tumor necrosis factor and other cytokines begin to act on that, the normal gap junctions that you see here, letting small amounts of fluid egress into the interstitium, actually widen. Why do they widen? Because tumor necrosis factor and these other cytokines actually cause each one of these capillaries to shrink and contract. So as each side shrinks and contracts, the gap junction increases in size. As the gap junction increases in size, more larger weight molecules are able to move from the capillary into the interstitium and drag fluid with it. Likewise, hydrostatic pressure pushes fluid through those capillary pores much easier. And so you get an extravasation, if you will, of the normal fluid and serum that's in your capillaries. It moves into the interstitium. So you become hypotensive, yet you continue to put on more and more total body fluid, okay? This is why someone who has a 20-25% total body surface area burn, let's say on one of their legs, will get edema not only of that leg, but the contralateral leg, the arms, the fingers, and the face, because this is a systemic response. It's different than what we see in trauma. Trauma, if I get my right leg crushed, I'm going to have obligatory edema and blood loss in the right leg, but I'm not going to get a lot of edema in the left leg. Burns, if I burn my entire left leg, I'm going to get edema everywhere. And that's what we need to do when we talk about fluid resuscitation. If we take a look at this slide of this patient that we have here, we see some of the facial edema that the patient's beginning to demonstrate. Most maximal edema that we see in our patient ranges between 8 and 24 hours. It depends on the size of the burn. The bigger the burn, the longer it takes to reach the maximum edema. And so sometimes when I'm thinking about whether or not I need to do escharotomies on a patient's arm or hand because it's getting swollen from the burn, I look and I see where am I during the course of the resuscitation. If I'm only a few hours into the resuscitation and they have all this edema, certainly when I give them a lot more fluid and they get more swelling, the situation is going to worsen. But likewise, if I'm getting near the 20th hour of the resuscitation, the patient's resuscitating well, and I'm getting kind of near the point I want to think about doing the escharotomies, I might not do them because I know I'm at the tail end of my resuscitation. So that's why it's kind of important to know what your maximum time frame is to reach the maximum amount of edema. Helps us think about what we're going to do next with other things. So in summary then, what's the end result of this? Increase in the gap junctions of the capillaries, the movement of fluid into the interstitium. It's a simple redistribution of the blood flow from the normal place that it is in the intravascular tree, shunting it away from the splanchnic bed, shunting it away from the heart, from the brain, etc., and putting it in the interstitium where we can't do anything with it. And so at a cellular level, we finally begin to see a mismatch between O2 delivery and O2 consumption because we're not able to meet the adequate blood flow that's needed throughout each one of the cells. So very simple, common pathway that occurs in burn shock, as well as hemorrhagic trauma shock, as well as in septic shock or cardiogenic shock. In the end, the low cardiac output, the low systemic blood pressure results in a maldistribution of oxygen and O2 consumption, resulting in cellular ischemia and or cellular death. What does that mean to our patient with a significant burn? It means that the depth of the burn is probably going to be deeper if we don't resuscitate them adequately. It means their kidneys are going to take a hit. It means their perfusion to all their vital organs are going to be somewhat compromised. So we'll see a bump in the liver function test, we'll see a bump in the renal function test, and we'll see very poor outcomes with respect to could we have controlled that burn wound bed to try and minimize the amount of damage that was occurred. We are actually going to maximize that damage because we're not going to get that collateral blood flow in there. Think of blood flow in burns just like we think of blood flow with heart attacks, okay? With myocardial infarction, acute coronary syndrome, if you don't reperfuse that area of the heart, that muscle dies. Ditto on if we're talking about cerebrovascular disease. If we're having a patient with a cerebrovascular event and we don't perfuse that brain tissue area, we have a central area of tissue that will become necrotic, a secondary area of tissue that will be ischemic, and a tertiary area that will be hyperemic. So these are what we try to control with adequate fluid resuscitation. So let's talk about some nuts and bolts here if we could. The goal of this is to maintain adequate tissue perfusion to limit the depth of the burn wound and to support the hemodynamics of the patient. We use the Parkland formula here at UC San Diego. The Parkland formula runs between 2 to 4 mLs per percent burn times the weight in kilograms. So even though we use the words per, probably what we really should say is 2 to 4 mLs times the patient's weight in kilograms times the total body surface area. That's the amount of fluid that we're going to give in 24 hours. We're going to give 50% of that or half of that in the first 8 hours and the remaining 50% in the ensuing 16 hours. And we'll talk a little bit about that and we'll work a quick problem on that later on. Our goal is to maintain adequate blood pressure and try to normalize the pulse as best as we can. And the very simple way that we can evaluate this both in the hospital and in the pre-hospital area is just looking at urinary output. Does a patient have adequate urinary output? For an adult, we want to see a minimum of 0.5 mLs to 1 ml per kg in an adult, and in children we like to see higher amounts, and we'll talk about that a little more. In the pre-hospital arena, you really have only two choices of what types of fluids to give with respect to burns, and those are lactated ringers and normal saline. We would prefer that you gave lactated ringers. It has a sodium concentration of approximately 130 milliequivalents per liter versus normal saline that has a sodium content of about 154 milliequivalents per liter. If we give large volumes of normal saline in a big burn resuscitation, we end up often with a hyperchloremic metabolic acidosis due to all the chloride that comes with the normal saline. We have less of that occurring with lactated ringers. So our preferential fluid in the field as well as in the hospital is a simple lactated ringers. We don't give albumin or other colloid resuscitation fluids in the first 8 to 12 hours because if you remember, we have those gap junctions that are very widened, and the colloid, the albumin particles can go through this gap junction, get in the interstitium, and as a result of that actually pull more fluid into the interstitium and perhaps even worsen the interstitial edema. So let's talk just a moment about a bird fluid calculation. If we have a 25-year-old male, he was in a structure fire, a house fire. He has a 50% total body surface area burn, and he weighs in at about 100 kilograms. Let's use the Parkland formula to go ahead and calculate what his total fluids are going to be for the day and what his fluids are going to be for the first 8 hours on an hourly basis, okay? So let's think back. What's the Parkland formula? Again, it's the percent total body surface area burned times the weight in kilograms times a fluid rate, which is 2 to 4 mLs per kg. I would like to use 4 mLs per kg because it's a bigger burn. On a smaller burn, I might just use 2 mLs per kg. So there's a little bit of a fudge factor here. The bigger the burn, the more you have to give. So put for 4 mLs in there. So let's go ahead and do the math on this. 50% total body surface area burn times 100 kilograms times 4 mLs. That's 50 times 100, it's 5,000. Times 4 is 20,000. So 20,000 mLs or 20 liters should be given in the first 24 hours of this patient's care. We give half of that in the first 8 hours, that's 10 liters. That comes out to be 1.25 liters per hour. So we're a little different than trauma. If you watch in trauma bay, once the patient gets in here, usually they'll get between 1 and 2 liters straight up when they come into the hospital. We're giving our first 1.25 liters over the entire first hour of this patient's disease process. And it's a pretty big burn, 50%. In the ensuing 16 hours, then we're going to give half of that rate, which is 625 mLs per hour, okay? And during all this, we're going to monitor the response to resuscitation as we usually do. Blood pressure, pulse, urine output, base deficit, serum lactate levels, etc. Simple things. This is a burn chart that we've included for the pre-hospital personnel. This burn chart gives the estimation of amount of fluid in mLs per hour for the first 8 hours of resuscitation. So you don't even have to do the Parkland formula. We base this chart on 4 mLs per kg. So we're basing it a little bit on the higher rate of fluid rather than on the lower rate. So if you look over here on the left side, this is the patient's weight and the weight in pounds. Right next to it is the weight in kilograms, 10, 20, 30, 40, 50, all the way down to 110 kilograms. If you look across the top here, you see the percent total body surface area that's burned running between 10% and 90%. Round up to the nearest percentage TBSA, likewise round up to the nearest percentage of the nearest weight of the patient. So let's go find our patient here. So our patient was 100 kilograms and had a 50% total body surface area burn. So if we look down here, we go down the weight and we find 100 kilograms. If we go across the top, we find 50% and we drop down, and lo and behold, there we are, 1.25 liters per hour. Just what we calculated back here, right? 1.25 liters per hour. Here it's just in mLs, 1,250 mLs per hour. That's what you give. So you don't have to do the math, you don't have to figure it out, you just have to do your best guess at what the patient's weight is and what the best estimate of your total body surface area burned is. And just as a reminder, TBSA for what we're doing here is not including first-degree burns. It's only second, third, or fourth-degree burns. It's only the big stuff. First-degree burn doesn't give off much tumor necrosis factor, cytokines, doesn't result in the same widening of the gap junctions, doesn't result in the burn shock process. This is a second chart that I want you to look at, and this is for children. Children really need to have IV dextrose running all the time. And the reason is the patient's brain runs primarily on carbohydrates when they're very young. They don't do very well if they're running on ketones. They don't do well running on proteins. And as a result of that, we need to have a maintenance fluid of dextrose running. And this is, again, is a simple chart. If you look here, we've got the patient's weight in pounds, and right next to it, the weight in kilos. 5, 10, all the way to 30 kilograms. This is the IV rate of D5NS that you should be running with these patients if they have 15 to 20% total body surface area more. This is the maintenance fluid rounded to the nearest 10. So a 5-kilogram child should have a maintenance fluid running of about 20 mLs per hour. A 25-kilogram child should have a maintenance fluid running of about 65 mLs per hour. Generally speaking, I will run this maintenance fluid in addition to the Parkland formula, okay? So particularly in the pre-hospital area where it's very early in the resuscitation, go ahead and give both the IV with the dextrose, normal saline, and give the full Parkland formula. Combine them and bring them into the hospital. We can fine-tune it once you get in here. So this is just a little bit of what I had said before, that the child needs to have a glucose as a substrate. What do we call a child? Really, for us, we like to say up to 2 years of age. In reality, it's probably only 1 year and under that we really need to worry about this phenomenon, but some children are a little bit behind on their growth curves, a little bit behind on development, etc. So to be safe, to catch all the outliers, we say age 1 day to 2 years, make sure you're running dextrose. Over 2 years of age, the little child's liver is a little bigger, has bigger storages of glycogen, can go longer. This little guy that we see right here will run out of glucose substrate in about 6 hours. By 8 hours, he'll be starting to run on ketones and proteins, okay? So we really need to give him some dextrose. He's just got a little tiny liver, he has a little serum reserve, and he has only a moderate amount of glucose normally in his serum. So just something to think about, okay? So how do we give the fluid? What do we need for access? Exact same as with trauma. 2 large bore IVs, preferably, okay? Both in the anycubes if you can get them there. Otherwise, find some other spot to get it. We try to stay out of the burned areas if we can. If we can. If it's burned on both the upper extremities and lower extremities and the external jugs, those areas are burned. Clean it up with a ChloraPrep, clean it up with some betadine, and just go right through the burn, okay? Usually the burn is that deep and bad. It's got a blister over it. It's got some char over it. Just clean that off with a rag and then use your ChloraPrep, and then go ahead and just start the IV. We'll remove that when the patient gets here and we can establish more of a central venous access for our patients. If you can't get the 2 large bore IVs, you're not going to get a central line access in the field because you don't have that type of equipment. But what you do have is the IO. This is one of the older versions of the IO. Now you all have the screw gun type of IO. We're going to put this in the patient's tibia. We're going to go 2 patient finger breaths below the tibial tuberosity. We're going to put it slightly on the medial side, the flat side of the bone, rather than trying to go right into the shin, the spine of the tibia. And we're going to get it in there and we're going to get it secured. After this is secured, we can go ahead and take the cap off this, put a syringe on there, draw back, and we should see a bit of a thick red gelatinous material of marrow that comes out, signifying that we're in. Go ahead and hook your IV to this and secure this to the patient's leg, but secure it in such a fashion that you're able to look under there and make sure this has not worked itself out, is not infusing into the anterior compartment of the patient's leg, because it doesn't take long to develop compartment syndrome if you do that. So I don't wrap this up real tight with the Curlex and then ace wrap and don't look at it for the next 2 hours. It's something that I do secure, and I secure it by just taking a cup, placing it upside down. I try to take a clear urine saline cup, cut a hole in the side so that IV tubing can come out, and then I tape that down and Curlex around that, and then I can move the Curlex from time to time and actually take a look. You can just put Curlex over this and secure it, Curlex or tape, but make sure you can move it so you can see it every so often. What do we use for monitoring how well the patient's resuscitated? Same things we look at in trauma. We look at blood pressure, pulse, we look at urine output. Urine output in burns is a pretty good surrogate marker of overall good perfusion. In an adult, we want to go between 0.5 cc's to 1 cc per kilogram. In a child, we want to do between 1 and 2 cc's per kilogram. We want to follow their acid-base status, we want to follow their serum lactate, their hematocrit, their electrolytes. And since I mentioned hematocrit to you and you're going back and you're saying, hey, wait a minute, this is not a trauma patient, this guy's not losing a lot of blood, why do I want to look at the hematocrit? The exact opposite thing happens in burns than happens in trauma, penetrating trauma. Penetrating trauma, the hematocrit goes down as you resuscitate them with fluids, right? It gets diluted. In burns, as we're first starting to resuscitate our patient, particularly on the big burns, 50% and above, we actually get behind in the resuscitation and our hematocrit begins to rise. So if a person comes in with a baseline crit of 45 and they have a big burn 50% or greater, we may find that that initial crit of 45 turns into 50, 53, 54 before we finally catch up with our fluids and begin to see the hematocrit normalize once again. And by the time we're done, it's actually about 5 or 10 points lower than when we started, but that's based on a dilutional etiology. So let's shift gears a little bit. We've talked a little bit about the initial fluid resuscitation. Just by way of review, we want to make sure we understand and demonstrate that we can calculate a Parkland formula, which is based on TBSA. And remember, the depth of burn that's included in the TBSA are only 2nd, 3rd, and 4th degree burns. So its Parkland formula is 4 mLs per kg times the weight of the patient times the TBSA. That's the total amount of fluid in 24 hours. You give half of that in the first 8 hours and the remaining in the next 16 hours. Let's jump over to a few principles of wound care. And for the pre-hospital area, this is pretty straightforward. We want to stop any further thermal injury. Sounds pretty obvious, but in the field, sometimes this is important because it's not been done by coworkers or friends. Number one, patient falls mopping a roof with tar. That tar is going to hold its heat for a long period of time. Hopefully the patient's coworkers or the patient themselves was able to get to a hose or to their water bucket and put that on the tar to cool it down. If not, that's the first thing that you can do when you arrive. Just get some water on this to make sure this thing is no longer hot and no longer still burning. Patients whose clothes have caught fire. Some of the nylons and rayons and some of the synthetics now in a hot fire will not necessarily burn on them, but it'll actually melt on them and hold the heat for quite a period of time. You want to make sure that that's not going on. If so, wash them down just with some simple water. If a patient has a chemical burn, we want to decontaminate that, and we'll talk about that on the next slide. So, some of the other principles of wound care is that it cleans the wound. So it's not that the bandage itself cleans the wound, it's that we're able to clean some of the dirt and debris off and we clean the wound. We then go ahead and debride all the bullae, all the blisters that are there. You say, well, what size blister do you break? We break everything that's over the size of a quarter. Why? The stuff that's in there, the fluid that's in the blister contains cytokines and other inflammatory debris that will actually slow the rate of healing of this. Now, that being said, if you're out hiking El Capitan and you get a burn from a campfire out there, leaving the blister intact is the most sterile bandage that you're going to have. So if I had a burn over the dorsum of my hand from hitting it up on a coffee pot or something like that and I'm hiking, I'm not going to break that blister. I'm going to leave that on, I'm going to clean it, I'm going to cover it with a little antibiotic ointment if I have, and something that's clean, a gauze or a clean kerchief or something like that. Okay, leave the debridement of the bullae, etc., to when they get to see us. We're then going to cover the wound with something that has some antimicrobial properties. That can be a topical antibiotic. It can be a piece of Xeroform, which has bismuth. It can be some of our silver products. All these things can act as great antimicrobial agents. And then we will go ahead and take the burn wound, if it's not healing, and take it for burn wound excision and coverage with autograft of the patient. So that's how I think about the burns in a big longitudinal sense. But out in the field, the practical sense here are, one, prevent some desiccation, and two, to prevent from infection from coming in. So let's talk just for a minute about what to do with a chemical burn. It's very simple. We just want to decontaminate the area in the patient that we're removing from the site of injury. If it's in a lab, we want to get them out of the lab area and get them to an area where we then can decontaminate them. And we want to lavage the area of the burn on their skin with copious amounts of simple tap water, okay? If the patient is covered with powder, make sure we take the powder off by dusting the powder as best we can. Put on your personal protective equipment, both for inhalation as well as for contact, so you don't get this on you. You might not know what it is that you're dusting off, but get that off the patient before you go ahead and lavage them with water. Lavage, lavage, lavage. After about 10 minutes of lavaging, you probably have more than enough water to have neutralized at least what's on the top of the skin, and it's time to transport them. Go ahead at this point, dry them off, put them in something that's warm and dry if you have it, or if something that is not warm because you're out on the rig, just something that's dry. Dry towel, a dry sheet, a dry ABD, and transport them that way. Just to digress just a little bit, you can remove the acid or the base from the superficial area of the skin. Once that's done, the acid that was initially in contact with the skin is going to be moving into the deeper portions of the skin, in the superficial dermis or in the deep dermis. You can't get that out by lavaging or lavaging anymore. It's past what you can do to help the patient. It's time to transport the patient. When they get to see us, depending on what type of acid and what type of base, we'll probably just let the acid or base run its course. But if it's a very, very concentrated stuff, we may actually excise that skin to get underneath it so that it does not continue to go deeper into the patient's wound area. So what can you really do in the field for your burn wound covering? Two things really simply. You want to put something on that is not going to let the wound desiccate and just dry out, and you want to put something on that's going to decrease the chances of infection if you have that. Short of that, this is what I'd like you to think about. Keep your dressing simple in the field. If you just go ahead and cover the patient with what you have, anything from a Curlex, an ABD pad, 4x4s if it's small, then wrapped in a Curlex, or just simply clean dry sheets, clean dry towels or pillowcases. Any of this stuff around the burn will work, because once you get them here, we're going to take all that stuff down eventually, look at the burn, wash the burn down, clean it, mechanically debride it, then bandage it up with the types of things that we talked about, the things to prevent desiccation, the things to prevent infection. Anything that you have will work as long as you keep it simple, clean, and dry. Some of these big burn pads that are out on some of the rigs in some of the cities, be very careful with those. They look like a big silicone pad that's filled with gel. It actually makes the patient feel better when you put it on, but it's a heat sink for the patient. So a small child with a larger burn, or even an adult with a large burn, when you put these jackets on them, it's really taking the heat off them at a rate that they're unable to keep up with. And in the end, I don't think really helps the patient. It does make them feel a little better. I would use those with extreme caution. We don't use them at the burn center at all. So I hope that I've given you a little something to think about with respect to fluid resuscitation for these burn patients in the pre-hospital arena, giving you a little bit of a history and our philosophy of burn wound care, but then keeping it very simple in the end with simple tables as to how much fluid to give per hour on these patients in the first 8 hours, because it's unlikely that you'll be holding on to these patients longer than just a few hours. And you say, well, hey, doc, we're never even hanging on to them for a few hours. Yes, you do. In the fires of 2003 and the San Diego wildfires of 2007, we had patients out in your rigs that were out there for 4 to 6 hours before they were able to get in to us. There were also a number of patients that needed to be transferred to outlying hospitals and then retransferred back into UCSD because of a combination of things. Traffic was too bad. Air transport was completely out because of all the smoke. So things that were happening out near Hamul, etc., stayed there. We did not see those patients for many, many hours after their injury. So this is stuff that you kind of have to think about a little bit, have somewhere in the back of your head. So I hope this has been useful for you. And again, thank you for your service to the community and keep up the good work.